Hi, all. I think we're going to get going. I am not Chuck Connors, nor am I Vineet. I'm Eddie Stenny, Vice Chair of the Department of Medicine. My honor to the first grand rounds of the new year of 2024, and we're in for an absolute treat. Dr. Guillermo Umpierrez will be presenting, as you can see, on the management of hyperglycemic crisis in adults with diabetes. And this is the new guideline that will be coming out from the American Diabetes Association and the European Association of the Study. Set the screen. Is it just, do I have to like eat the mic? Like right here? As an ID physician, this feels a little bit weird to be literally kissing the microphone. Nobody will be able to use this. Like I said, this is going to be the first presentation of these guidelines today. So in for a treat in terms of getting a first glimpse of it. Dr. Umpierrez, who's coming to us from Emory University, a place where I trained as well and know these folks, and he's a professor of medicine in the Division of Endocrinology and Metabolism. He is also the director of Grady Hospital's Clinical Research Unit, part of the Atlanta CTSA. He completed medical school at the University of Guayaquil in Ecuador. He was instructor of medicine there for a short period of time before coming to Emory University, where he did his training as an intern, a resident, and then a fellow. He joined Emory faculty in 1992 and has been a full professor there since 2007. His accolades and accomplishments are extensive. I'm not going to be able to review them all today. He's garnered an extensive collection of national and international and in teaching, clinical care, mentorship, research, and the list goes on and on. He received Atlanta's Top Latino Physician Award 8 times, I saw on your CV, and he's also served as the president of the American Diabetes Society in 2022. His research interests include mechanisms of beta cell dysfunction in minority populations, prevention of acute and chronic diabetes complications, and hospital management of patients with diabetes and hyperglycemia. He's a national and international leader in the field of hospital management of diabetes and has published and marked papers and guidelines in the field. In addition, he leads Emory's Latino Diabetes Education Program and nationally accredited Spanish Diabetes Education Program dedicated to providing diabetes education to Latinos. With that said, please welcome Dr. Umpierrez.
Thank you so much, and thank you for inviting me. It is so good to come to the university, have dinner with the faculty, meet the fellows, and give lectures and go back home the following day, like the pre-pandemic thing that we used to do. And during the past 2 years, I have been working with several societies that are listed down here in updating the American Diabetes Association management guidelines for hyperglycemic crisis. And I've been told this is the first presentation, so let's see how this is going to go. We presented in Germany at the European meeting. We will be presented this in June at the ADA. So these are potential conflict of interest. Emory University has received money from these companies, and I've served as a consultant for these 2 companies listed here. And the objectives of this update is to provide an up-to-date knowledge on what is hyperglycemic crisis. Why do we care? What is the epidemiology, diagnosis, treatment? And the goal is the audience is to have the full spectrum for everybody who does diabetes care in the hospital and outside the hospital. So why updating the guidelines? This was the first time in 2001 that the American Diabetes Association put together an update. It was 2001, Avi Kitachi is my mentor, and we did it together. We updated this in 2006 and in 2009. And during the past 13 years, nothing had happened. So there have been papers like this asking, come on, we need to do something about update because there are many new areas that are going on in diabetes care. So if you go to PubMed, and this is a very brief highlight, you get close to 6,000 citations for GKA up to a couple months ago from 2009, from the date that we've got these guidelines. HHS about 485 hyperglycemic crisis. So there are 5,000 days. So we work together with epidemiology, we work together with clinicians, and people from different areas to try to put together the most updated update. And we have 8 different questions that we placed. So the first one is going to be epidemiology. What's going on with outcome, with epidemiology, with mortality, cost? Second, pathogenesis, not much about it. Diagnostic criteria, that's some of the new changes that we are recommended. Treatment, also, there are several new recommendations about treatment, not only insulin, but also fluids and potassiums. What do you do with the patient after you treat them in the hospital when the patient go home? What are the recommendations? We talk about complications, and we have a section on special populations. So, and areas of future research. The last 2, I'm not sure we're going to have time to review, but these papers should be published in Diabetes Care and Diabetologia in the next month or 2, I don't know, whenever they say. So epidemiology. So during the past 10 years, there have been a significant increase in the admissions rate in the United States and in Europe for patients with type 1 and type 2 diabetes presented with hyperglycemic crisis. There is no much data on HHS. So if anybody's interested, that would be an open field that our group have not tackled. But there is many patients with HHS, and you will see in a few minutes, it's associated with significant increased morbidity and mortality. There are recurrent episodes. And the other thing that is new, or not new, but we bring to the attention of you and everybody else, is that it's not type 1 diabetes. 30% of people with DKA have type 2 diabetes. And those with newly diagnosed diabetes, many of them with type 2 are able to come off insulin. This is a condition that we call ketosis-prone diabetes and type 2 diabetes. And we have a section on that. And the other thing that we want to call to your attention is that mortality before the discovery of insulin was 95%. Right now, mortality of DKA is less than 1%. So we're done very well. So if you look at data in the United States, this is the number of admissions per year in the last 20 years, during the last 20 years. And it has gone significantly, like 40 to 50%. So this is supposed to be a preventable disease. That's right. If you have type 1 diabetes, type 2, you are going to be treated with insulin. If you do glucose, you should prevent diabetes ketoacidosis. Unfortunately, the number continues to increase. In Europe, it's the same story. Here you have from the UK, and the left is type 1 diabetes, into the right is patient with type 2 diabetes, and you see that the prevalence continues to increase in both the United States and in Europe, both in type 1 and type 2 diabetes. When you look at DKA, people will think, yeah, this is type 1 diabetes. That's right. It's not the case. About 60% have type 1, about 40% have type 2 diabetes. When you look at, if you think about DKA, you think young children, young people. No, now people with type 1 diabetes live longer. So most patients with DKA, adult patients, have type 1 diabetes. Most with type 1 are adult, and about 30% have type 2 diabetes. We always think hyperglycemic crisis are 2 worlds. One is DKA and the other hyperglycemic hypersmolar syndrome. But 30% of them has both, a combination of both. This is data from our group. And you have in the 1,200 patients from Emory University, you see that DKA is more common, HHS is less common, but about 35% have a combination of both symptoms. Precipitating cost depends what part of the world you live on. This is data we published several years ago. And in the United States, the #1 cause is lack of insulin or insulin omission, lack of adherence to insulin. But in other countries, infection is the #1 cause. Newly diagnosed diabetes could be another one, and precipitating cause. So there is no pattern. In Atlanta, Georgia, I work at Grady Hospital. It's a metropolitan hospital, 1,000-bed hospital, with 30% of people have no insurance. And 50% of our patients because they don't have insulin, or because they cannot afford, or they just go and don't take insulin. In the last few years, we got the issue of COVID. And this is data from the UK. And the number of patients with COVID who developed GKA, 7% of patients with diabetes at Emory admitted with COVID are presented with diabetic ketoacidosis. And it can happen in patients with type 1 and type 2 diabetes. In the United States, most people with COVID and DKA have type 2. In Europe, it's type 1 diabetes. And the other thing that we learned in the last few years, unfortunately, is the number of DKAs due to SGLT2 inhibitors. In patients with type 1 diabetes, if you start somebody on SGLT2s, the dapagliflozin, empagliflozin of this world, about 6 to 10% develop ketosis. So beta hydroxybutyrate goes above 2 to 1.5, 2 millimole. And about 2 to 4% develop DKA. And that is why the FDA has not approved the use of SGLT2s in patients with type 1 diabetes due to the increased risk of diabetic ketoacidosis. SGLT2, in addition to type 1, has been reported in type 2, especially in those patients who are going to be NPO for several days. Those patients, for example, the classic presentation is somebody who's going to get bariatric surgery, who don't eat for several days. If they're taken for SGLT2, there are multiple reports on DKA. So the recommendation is people who are going to be not eating for 2 or 3 days, you should hold the SGLT2s because of the risk of diabetic ketoacidosis. And we also learned that many of these patients, because the way that this agent, SGLT2, work is producing glycosuria, so they bring the blood glucose down because you flush glucose through the urine, many of these patients present what we call euglycemic DKA, so glucose less than 200. And that has been reported in many patients who are taking SGLT2 inhibitors. What about mortality? So 95% now mortality is less than 1% in Europe and the United States. In HHS, significantly higher mortality in these patients. But there are some circumstances that you have to take in consideration. So if you work in a place like I do, where a lot of patients come over and over, we call them frequent flyers, patients who come with TKA over and over. I have patients with more than 50 episodes. And one day they stop coming. We thought that maybe they just went to a different hospital. No, they die. Look at mortality rate. If you have one episode of TKA, it's less than 1%. But if you have 2 to 5, the mortality increased by 3-fold. And you happen to have 5 episodes of TKA, and you are readmitted recurrent DKA, mortality is increased by 6 to 8-fold. So we have to be very aware of this condition in those patients with recurrent DKAs to prevent mortality. Not only the cause of hospitalization, the issues, morbidity and mortality is quite high. And the other thing that we learned from our data and from other people is that it's different mortality if you have DKA alone, if you have HHS, higher mortality, but if you have the combination of DKA and HHS, this is somebody that you need to put in the ICU because mortality is significantly higher in these people. It's 3 to 5-fold increase in mortality. So the combo or the mixed DKA, HHS is a serious condition. And finally, regarding to mortality, we highlight the importance of COVID infections. Here you have in 5,000 patients, we published in JAMA a couple of years ago, and when you're looking here to the right is age. If you have COVID and DKA or hyperglycemic emergencies, mortality in those patients over the age of 65 is 40%. COVID and mortality is increased. I mean, even no DKA, just in everybody, age is an important factor. But look at mortality in those patients with DKA compared to those patients with no COVID infection. So now we're following patients. We have a cohort of patients that we're following at Emory who had DKA, diabetes, or newly diagnosed during COVID to see what happened with these patients long term. Don't know yet. This issue about cost is quite interesting. Here you have hospital charges in the United States from 2003, 2014, 2017. Look how much, this is charges, this is not cost, has to be adjusted for Medicare. But look at the length of stay. So despite that we decrease the length of stay, the cost goes up. But if you go to Europe, in the United States is about 30,000. In Europe it's about 3,000 euros. So I guess something is wrong with the way we charge patients. We charge 10 times more what the European charges for these patients with the same hyperglycemic crisis, despite that in Europe, they stay longer than they stay in the United States. So pathogenesis, not much has been written about pathogenesis. All these studies were done in the 80s, in the 1990s, no studies after 2000. But again, we have two worlds, that's right, the DKA and the HHS. And the previous study is trying to differentiate, saying that DKA is less insulin and HHS is more dehydration. Well, both of them are insulinogenic. And most of them are associated with dehydration. So there is difficult to differentiate in pathogenesis, especially because 30% of patients has a mix of both conditions. So here's what we got this new graph, I guess. We have a nice guy who is an expert in making beautiful graph for these publications. So all hyperglycemic emergencies, everybody who comes to the hospital with glucose greater than 500 is insulinogenic. If you have enough insulin, your sugar shouldn't go above 500, 600. So HHS and DKA have decreased insulin secretion, and they have increased contrarregulatory hormone, the cortisol, the glucagon, the growth hormone of this world. So in the lack of insulin, what you're going to do is get fuels from fat. So you increase lipolysis, and you get free fatty acids. And free fatty acids are converted to ketones. And of course, ketones are strong acids that needs to be decreased bicarbonate concentration. They need to be buffered. Patients with HHS, they also have decreased insulin concentration. They also have increased contrarregulatory hormones. Whoops, sorry. Oh my goodness. Oh. And with increased glucose, both in DKA and HHS, you become polyuric, you become decreased renal perfusions, you get decreased volume depletions, and you get a lot of inflammation and osmolality. These are areas, or this information has not been updated during the past 20 years in the literature as far as we were able to find. Nobody has taken the time to look at what happened with HHS, what happened with DKA, and with respect to pathogenesis. So good areas for researchers, I guess. So things that we care about. We are clinicians. The clinical presentation, DKA, this patient has very little insulin concentration. So if they miss 1 or 2 shots of insulin, basal insulin, they develop DKA in the matter of hours to a couple of days. HHS, they still have some insulin, so it takes several days to develop. And it's usually you're going to see that this patient with HHS as older adults who have been dehydrated and poorly controlled diabetes for quite some time. They all present with polyuria, polydipsia, and weight loss. Something for a clinician is the abdominal pain and nausea and vomiting. Patient with DKA is associated with abdominal pain. HHS, high blood glucose by itself, does not. So if you have a patient with glucose of 500 and the patient complains no ketoacidosis, complaining of abdominal pain, you should work him up or work her up. If the patient has DKA, you should treat the DKA and the pain goes away in the matter of 12 to 24 hours. So this is something very important to us. And of course, patients with DKA, due to the metabolic acidosis, have Kussmaul breathing. Dr. Kussmaul is a German physician in the 1890s described. And at that time, they didn't have beta-hydroxybutyrate and ketones. They divided the DKAs into the diabetic comas in 2 ways. With Kussmaul breathing, that means DKA. Without Kussmaul breathing, that means HHS. The diagnostic criteria, we made very small changes. The main change is that we changed the glucose concentration. It used to be 250. Now we call 200. And the reason why we changed to 200 is because there's a lot of patients who present with euglycemic DKA. And the other thing that is new in this update is that if you have a history of diabetes, I don't care what your blood glucose is. If your ketones are elevated, you have acid-base metabolic acidosis with ketones, and you have a previous history of diabetes, your glucose could be 120, 150, 180. So it's independent of the glucose concentration. You should diagnose DKA in that way. The hallmark is ketones. your body produces keto acids, that's right? So that's what it gives you the metabolic acidosis. In the United States, unfortunately, and this is a big push that we're doing, 50% of hospitals in this country diagnose DKA by urine acetoacetate, which is not the best way to do it. In Europe, 80 to 90% do beta-hydroxybutyrate by laboratory or by finger sticks. I know that in this university, you guys do beta-hydroxybutyrate. Perfect. We do the same at Emory. But 50% of laboratories in this country, they still rely on acetoacetate in the urine, which is not the best way to diagnose or assess the response to therapy. And metabolic acidosis, we didn't change it. And well, 20 years ago, we changed to bicarbonate to less than 18 or less than 15 that used to be in the past. So what's new? Hyperglycemia 200. 10% have euglycemic DKA, so that's the reason why we move it to 200. I've been a lot of critiques and comments about why we move it to a 250. But if you have anybody with glucose greater than 200, that patient has diabetes, that's right. So why not in patients with diabetic ketoacidosis? Ketones, more than 3 is abnormal. That's the definition. It correlates with acid-base disorders. We strongly recommend beta-hydroxybutyrate. Urine acetoacetate is not good. So for diagnosis, you have 2+, the sensitivity is more than 90%. Perfect. But during treatment, your acid base is corrected. Your bicarbonate goes up to 18, 20. 50% of people still have positive acetoacetate in the urine. So there are multiple studies indicating that if you follow acetoacetate in the urine for resolution of TKA, that is associated with prolonged need for insulin, increased length of stay, and shouldn't be done. Now we have beta-hydroxybutyrate by point-of-care testing. The very good sensitivity and specificity. Of course, the laboratory by enzymatic methods can also measure beta-hydroxybutyrate. So we would love to see a change in the way we practice medicine in this part of the world compared to the Europeans. Ketones. Okay. The other area that we work is on trying to help clinicians on how do you assess severity? That everybody needs to be admitted to the ICU, or you can just treat people in the regular floor. So we put this table together in the previous guidelines. We make many small changes. So we have here mild, moderate, and severe TKA. Those patients with severe TKA needs to be to intensive care area or to an area of very close supervision, because mortality in those patients who have severe TKA is about 3 times higher than those patients with mild to moderate. Ketones, metabolic acidosis, it was the way we did it before. So mental status is perhaps the most important issue. If you have somebody who presents with hyperglycemia, let's say glucose of 400, and the patient is obtunded or in coma, you work him up. Because the only reason why you should have altered mental status is with severe hyperosmolality. So if you know they have patients with meningitis, we get 1 or 2 cases every year at Grady. They present in coma, they present very obtunded with high blood glucose, and you have very few hours until you start your antibiotic to improve prognosis of these patients. So we recommend that if the patient is in mental status, is in coma, has to be worked up, has to be to the ICU or to a high supervision area. And again, as I mentioned before, mild can be treated. We treat most of our patients with TKA, especially those with recurrent TKA in the emergency room, because they wait for so many hours to get a bed upstairs. So we just treat them when they're clean, and we just do 2 observations in 48 hours. And we don't move anybody to the ICU unless they have coma, stupor, or the precipitating cause merit to have admission to the ICU. There are multiple studies indicating that the outcome is the same. The difference is just saving money, not for use of the ICU unit. So HHS, hyperglycemic hyperosmolar state. And if you notice, we don't use the name coma, that's right. because most people with HHS DKA are alert or stuporous. Very few of them are in coma. So hyperglycemia more than 600. Hyperosmolality can be calculated in two ways. Total serum osmolality has been the way we have done forever. Here is the formula, taking sodium times 2, glucose divided by 18 or 1 millimole, plus urea divided by 2.8 or millimole. And in the 2009, we moved to prefer effective serum osmolalities, not taking in consideration the urea. Urea goes freely from the membrane in and out. It's not associated with alteration of mental status. You see patients with uremia, with a urea of 80, 90, so the osmolality is high, but the patients are alert, they are talking to you. So do you have to use effective or total serum osmolality? In 2001, we went to total. It went to effective. Now it doesn't matter. More than 300, more than 320, there are several studies that we cite in the paper that are associated with severe, with HHS. Absence of ketonemia, so they have to have a beta hydroxybutyrate less than 3 or urine ketone less than 2 plus. Absence of acidosis, this HHS. But remember that 1/3 of patients has both. So do you really have to say, do you're DKA, you're HHS? Yes, only because HHS is associated with 5-fold increase in mortality. And those patients with combined, they tend to have more problems, so they have to be admitted to the ICU. So in the management, this is not to be supposed to be read, but what it is three things. We concentrate in fluids, we concentrate of insulin, and we concentrate in potassium. And to the right lower quadrant, there is a little quadrant box there on bicarbonate and phosphate, but we don't recommend anymore except for some special situations. So insulin. So in these new fluids, in the fluids, we changed that. We always recommended normal saline. I don't know which solution you use. At Emory, we always use normal saline. But in the past 5 years, there have been at least 6 to 8 randomized control studies suggesting that the use of crystalloid solution, the lactate ringer, is as good or perhaps even better than normal saline. You have less length of stay. Most people with normal saline go from a high annual gap to a normal annual gap metabolic acidosis. And that may prolong length of stay in this paper. So for the first time, we're recommended that you can go either way with normal saline and crystalloid solutions. At Emory, normal saline is more cheaper. It's cheaper, so we still use normal saline, but you can do either way. There are many areas in this world where they use more lactate ringer instead of normal saline, and that is appropriate. Insulin, since 2004, 2008, we have several papers that you can treat patients with rapid-acting insulin sub-Q. And the resolution is exactly the same as IV insulin. At Emory, we do that all the time. At Grady Hospital, we do all the time. We treat with sub-Q insulin those patients who have mild diabetic ketoacidosis. And you just give 0.1 units per kilo every hour, so 5 units, 7 units. And it's as good as you give 0.1 units every hour. The time to resolution, the length of stay, the complications is exactly the same. You can also do 0.2 units every 2 hours. And there are several studies confirming that. If you have a patient with severe DKA, if you have a patient with HHS, please don't use sub-Q insulin because there is no data at all. So do should treat this patient with IV insulin. And we have these guidelines, how do you have to do it? And we're going to have some slide set coming up that is going to educate primary care physicians. Remember that most people with diabetic ketoacidosis, HHS, are treated by hospitalists. Endocrinologists don't go to the hospital too often. So we have to educate primary care, the emergency room physician, because these are the ones who are going to treat this patient with DKA, HHS. Potassium, extremely important. So potassium in patients with DKA, HHS usually is normal or elevated. And it's because potassium is intracellular, but it goes inside, outside the cells. It's guided by the sodium potassium ATPase. In the lack of insulin, it doesn't work. So potassium hangs around outside the cells. But as soon as you start with glucose, with insulin, you start fluid. Potassium is going to come inside the cells. And everybody present with hyperglycemia, severe hyperglycemia, you start on insulin therapy, potassium is going to drop about 1 to 1.5 millimole. So if you have a patient who have low potassium on admission, let's say you have a patient with 3.3 or 3.5, and you're going to start insulin therapy, he can go to 2.5, 2.4, 2.2, and it's associated with muscle weakness, arrhythmias. So we emphasize that look at the potassium levels. The other thing is if you have a potassium of 6.5, you don't have to treat it except just start insulin. You give fluids and insulin, and potassium is going to drop. So don't give bicarbonate, don't give calcium, just give insulin. And keep in mind this transfer of potassium inside the cells, outside the cells. We want the potassium to stay between 3.5 to 5. So we have some recommendation how much potassium you have to give to these patients, and that's going to be in the guidelines. Bicarbonate, there are 6 or 8 studies suggesting that it doesn't work. It doesn't matter if you use or not. But of course, severe acidosis, maybe less than 6.9. The guidelines say 7, but nobody has tested. It's really how low you really have to start bicarbonate therapy. But there are 6 to 8 papers saying that use of bicarbonate therapy doesn't change the outcome. So, but we didn't have data, so we just kept with the old recommendations that if it's less than 7, you may use bicarbonate. In our institution, we only use if it's less than 6.9. Phosphorus, there are several studies, large studies, multi-center studies suggesting that it doesn't work. Now, what happens if you give too much phosphorus like we used to? So it binds to calcium. And there are several patients who develop hypocalcemia, even have seizures, especially in children. Remember that calcium comes in 3 flavors. It comes free calcium, that's the one who works, bind to albumin, and complex, so sulfates and phosphate. So if you give phosphate, too much phosphate like we used to, level of calcium can drop significantly during treatment of GKA. So we're not recommended. What we do at Emory, we just give milk. It has enough phosphorus, so you give a little carton of milk, and that's going to be 1 millimole per ml. So it's more than when you give IV to these people. Skim milk is very good to do it. So criteria for resolution. We changed a little bit here. We used to say 15. Now we want to be more conservative. And we want the bicarbonate to be equal or greater than 18, and the venous pH equal or greater than 7.3. The ketone levels, normal is less than 0.5, 0.6. DKA is 0.3 and more. So in between, you are resolving GKA, but and the glucose should be less than 200, 250. The glucose is the least important, I believe, to me. It's the bicarbonate and the venous pH. Resolution for HHS, the hyperosmolality be resolved. So make sure the osmolality is less than 300. I hope that the glucose should be less than 200, 250. And more importantly, that the mental status has improved. So it could be that there are reasons why the mental status is decreased, like stroke. But in general, after 12 to 24 hours, patients are going to improve mental status. And we want mental status to be improved because that is associated with increased morbidity and mortality. We have a section on transition of care. Remember, the half-life of IV insulin is somewhere around 8 minutes, 6 to 10 minutes. So when you are ready to switch this patient from IV, you have to give sub-Q insulin at least a couple hours before you stop the drip. If not, there is recurrence of hyperglycemia and even ketoacidosis if you are delayed in the transition. So very important. If you're going to use NPH, and we do it 2 hours. If you're going to use glargine or the long-acting basal insulin, maybe 2 to 4 hours. Give the dose before. And usually we do it just before meals. We have these beautiful tables. We're just going to highlight where we are. So this was an area of lot of controversies among the group. We are 10 of us or 12 of us. The way that I've done always, the guidelines always says, if you have somebody who is newly diagnosed, we're going to start somebody on 0.5 to 0.6 units per kilo. So somebody like me, 30, 40 units. And you give half basal and you give half prandial insulin. That's the traditional way. The other thing, I believe that you should look at the pre-admission requirements. So if somebody just went partying for the weekend and developed GK on Monday, just look at the previous dose. And if the patient was fairly well controlled, you start on that dose. Most people are poorly controlled, so you have to adjust this dose. A lot of Europeans wanted to use this insulin requirement per hour, which I'm not sure I agree, but it was a consensus, we put it on. So what's the problem with taking in consideration how much you require? The time to resolve hyperglycemia in patients with DKA is 4 to 6 hours. That's it, 4 hours, 6 hours. And the time to resolve ketoacidosis is about 10 to 14 hours. That you have what is called glucose toxicity. We start on 7, 8 units per hour. That when we switch them, it's 0.5 units per kilo. So about a third of the insulin. This is because the body is resistant to insulin when you have been hyperglycemic. But if you are somebody in the ICU on continuous insulin infusion, this worked very well. In patients with DKA, I have not seen any studies. I was the chair, but several people from Europe says, no, this is the way we do it in Europe, so here you go. It's up to you if you use it. General point. Or other things. Again, 1 or 2 hours before, the use of non-insulin agents. So SGLT2s have been associated with TKA. In a patient with type 2 diabetes who developed TKA being on SGLT2, what happened? Can you restart SGLT2s when the patient goes home? We were not able to find a single studies on the safety. If you do it once, you can do it twice, that's right. So you have to be very, very careful in this group of people. So type 1, please don't use SGLT2s. And the other thing that we have a section in there is those patients with type 2 diabetes, what is called ketosis-prone diabetes, especially Latinos and African Americans. So we have somewhere around 250 admissions for TKA per year. 17% of them have newly diagnosed diabetes, and half of them have type 2 diabetes. So we have about 30, 40 patients a year. So these patients are able to come off insulin within 10 weeks of follow-up. And multiple studies, and I know you do studies here in this atypical DKA, and we have a protocol and we include it in the guidelines. Knowing that if you have type 2 diabetes going to DKA doesn't mean that you have to be on insulin for the rest of your life. About 50 to 70% of them, if they're newly diagnosed diabetes, they are obese, they can come off insulin. And at this chart, make sure that you give enough insulin supplies, that's right. I mean, we see so many people going home, they didn't get the insulin, they are come back. 30% of patients with recurrent DKAs are within 2 weeks of discharge. This is our failure, I guess. Here in this university, Boris Drasnin published a paper that when you start insulin drip, you can give a little dose of basal insulin. And that prevents recurrence of hyperglycemia. Following that paper several years ago, there have been 6 or 8 studies that when you start insulin drip, you give a small dose after 2 to 4 hours of basal insulin, and that helped preventing hyperglycemia. We didn't put it in the guidelines. We put a section there in the text, but not on the graph, because I don't think we have enough data to really confirm this is the best way to do it. Let me finish with, I think this is one of the most interesting sections, is what do you do with complications? So the number one complication is hypoglycemia. It's seen in somewhere around 15 to 30% of patients with TKA. Imagine now, let me bring you to think about this. You come with a glucose of 800, and I told you 4 or 6 hours, your blood glucose down. And you for 400 or 800, you go to 40. And these changes in osmolality have been associated with increased risk of complications. So hypoglycemia must be prevented because hypoglycemia is associated with fourfold increase in mortality. So just be aware that the brain is not happy if you go from osmolality of 320 to less than 280 or the glucose of 800 to 40 within the next 12 hours. So mitigation, frequent glucose monitoring. And we recommend the use of finger sticks. We have a study with the University of Columbia in New York using continuous glucose monitoring. It works, but the data is very, very small. So far, we want you to do finger sticks every 1 or 2 hours during treatment of GKA and during the transition period to sub-Q insulin before meals and at bedtime. Can you do CGM? Likely, yes, but the CGMs are not approved to be used in the hospital. What about hypokalemia? The hypokalemia is, according to Francisco Pascal, who worked with us, he published this paper that is seen in about 50% of patients. This is a retrospective analysis. I think that's a little too much, but anyway, if you have hypokalemia, it's also associated with significant mortality. So we want you to measure potassium 2 hours after you start insulin infusion and every 4 hours during acute treatment, and then daily when the patient is on the maintenance dose. Monitoring is the way to go. Be aware if you come with a glucose of potassium less than 3.3, 3.5, maybe you should give potassium before you start insulin therapy. You start IV fluids. IV fluids by itself bring the blood glucose down by 75 to 100 milligrams per deciliter per hour without insulin. So just give fluids, give a round of potassium, then you start your insulin therapy. You may improve outcome in these people. Thrombosis and DVTs and strokes have been associated with hyperglycemic crisis, both DKA and HHS. And no good data, so that would be a nice study to do. But because, and despite the lack of data, we're recommended to use low molecular weight heparin in these people. Remember that a lot of these patients have nausea and vomiting and has Mallory-Weiss, and they may have some little bleeding here or there. So you have to be careful about those individuals. Cerebral edema, I already touched on that. Please be aware of that. Don't bring that osmolality too fast. Take your time. It took hours to days to weeks to this patient to get to the glucose of 600 to 800. There is no need to rush. So take your time, and of course, that may improve outcome in these people. So the final area that I think is interesting is how do you prevent? So if you work with me at Grady Hospital, 50% of cases are because you stop insulin. 80% of recurrent DKA, more than 2 or 3 admissions because you stop insulin. So education is a must. The other thing that we want is to assess depression. One of the areas that we're working on is depression. If you have depression in type 1 diabetes admitted with GKA, the rate of suicidal attempt is about 6-fold compared to those people with no diabetes. So a patient with diabetes has a lot of depression, has a lot of issues, so you have to be careful and look for depressions and treat them according to prevent recurrent admissions. So look at the social determinant of health. The patient have insulin, not insulin, has money, not money, has social support, not. So there is a long list of things that we put in these guidelines. How you can prevent recurrent diabetic ketoacidosis and HHS. And these charts, please educate your patients on 6 days. Make sure that they don't stop the insulin. Look for the injection site, that's right. Make sure it's simple things that we do. When you put insulin, don't go in and out. You push in and you count up to 10 before you pull out. If not, half of the insulin goes to your shirt. So just education, ketone testing. Now we're going to have in the market continuous ketones monitoring. The same like we have continuous glucose monitoring, we're going to have continuous ketones monitoring. We are starting trials to see if continuous ketones monitoring may prevent recurrence of diabetic ketoacidosis. And the study to the right is just those patients treated with CGM from France have been showing that using CGM in these patients decreased the readmissions rate significantly in patients with TKAs after 12 months. And make sure you give enough insulin supplies, right? That make sure that could be very important. Now, I'm not going to touch about this, but the guidelines, we have a section on frailty, older adults. How do you manage these patients? Not everybody needs to be on insulin. Hypoglycemia in the frail and the older adults, especially those with sarcopenia, are associated with increased risk of falls. So you have to be very careful in the older adults. Keep the hemoglobin A1C somewhere around 8%. Don't tight control them. SGLT2s we already mentioned. There is a section on end-stage kidney disease. How do you manage this patient? You cannot give fluids, tons of fluids. You have to give very small. You cannot give potassium. So we dedicate a section on how do you manage patients with end-stage kidney disease and dialysis. There is a section on pregnancy. It is important in the way that many patients who have type 2 and type 1 diabetes develop DKA, hyperglycemic emergencies during pregnancy. How do you manage these patients? How do you manage when the patient comes to the delivery room? How do you manage with insulin therapy? Remember that the placenta is gone, insulin resistance is gone. You have to adjust for insulin therapy and COVID that I already mentioned to you. So I want to present to you the team. There are several people from the United States. There are people from the European, the American College of Endocrinology, the UK Diabetes, and the Diabetes Technology Society. And we worked together for about a year and a half. So, and now we see what happened. And let me finish for the young people. I think that when you are called to do this kind of work, you acknowledge people who have been incredible in the improvement of care in patients with hyperglycemic crisis. And we thought that Banting and Best should be outlined. And these two guys, Sir Giorgio Alberti and Avi Kitabchi. So, Banting and Best, you're seeing here what happened in glucose concentration and the first patient ever treated with insulin. It was at Toronto General Hospital. A kid, 14 years, very malnourished and needed with a glucose of 580 milligrams. And what they did is give insulin extract. They didn't have insulin, sub-Q, regular insulin. They have just insulin extract. And what you see, each one of them is a little dose that they got, and you're looking at glycosuria. Within a few hours, glycosuria went away. And in the right side is ketones. They already have, in 1923, they have measured ketones, acetoacetate, in the urine. And it went away. And this kid was the first person ever to survive an episode of diabetic ketoacidosis treated with insulin. He died a couple of years later because he was very poorly controlled and he died with a pneumonia attack. And the father in the Europe of diabetes and DKA hyperglycemic crisis is Sir Giorgio Alberti. He's a professor of medicine. And he was the first one who told us that we don't need to use huge doses of insulin. Before 1973, the average insulin dose for treatment of TKA was about somewhere around 500 units per day. People got 100 units IV or sub-Q and 50 to 100 units every hour or every 2 hours. Of course, there was a lot of hypokalemia. There was a lot of hypoglycemia. So Alberti says, maybe we don't need that much. And he just gave 7 units to 10 units every hour. And the treatment was as good when you give 50 units an hour. Because, you know, when you give insulin, you saturate the receptors. It doesn't matter. Then you just achieve your goal. So you don't need the 500 units. The insulin dose in our units is about 80 to 90 units to resolve DKA for most people. And Avi Kitabchi was my mentor. And he was the one who did all of these randomized control studies. Is phosphorus good? Is IV insulin. Do you have to give bolus doses or not? And he's the one who really moved things together in this country. And because he was my mentor, of course, I acknowledge him a lot. So let me say thank you and open up. You know, I'm thinking while I'm presenting this to you is that this is the first presentation that I'm doing this. Going to make some little changes here and there, but I think that it is time. And I hope that when you read this paper and hopefully you instruct the emergency room, the hospitalists, the students, the residents, and how best to improve outcome. Because if somebody dies with GK, nobody should die of GK or HHS. Nobody. We know how to treat it. There is mistreatment, what really is associated with the complications. So thank you so much for inviting me, and it's so good to be here.
Thank you so much for that presentation. A new guideline, well anticipated. I see endocrinologists, hospitalists. I'm sure there's not going to be a shortage of questions.
Thank you so much for that really terrific presentation. Also, thank you for your leadership in this field, for the research that you do, the mentorship, and all the clinical care. So I did see one glaring omission from your presentation. And so I was wondering if you could focus on and comment on anion gap. So there's a huge emphasis on that, I think, in a lot of people's care. So could you comment on what that discussion was like?
Anion gap, and we got, have you ever had a paper that you send and you get 320 edit or comments that you need to address? 320 almost died. And because there are 8 reviewers and 5 organizations, many of them were repeated. So it was easy to look at this one, look at that one. But main issue was anion gap. And many institutions use anion gap for diagnosis and for treatment. And we says that you can do anion gap, no question. But the main diagnostic, the main state of diagnosis is beta-hydroxybutyrate. And that should be, there's a lot of people who come with nausea and vomiting. They get metabolic alkalosis with contraction alkalosis. So the acid base is not as accurate. 30% of them has that. The other thing is doing treatment. You treat with normal saline, and normal saline has a concentration of sodium and chloride of 154 millimole. So the chloride normally in our blood is about 100 to 110. Now you give 154, and anion gap is calculated sodium and chloride minus chloride. So you're going from a high anion gap to a normal anion gap metabolic acidosis. So it is not a good way to define response to therapy. And that's what we emphasize in these guidelines, that maybe you just have to use beta-hydroxybutyrate, glucose, look at the bicarbonate. That's much better than use the anion gap. But I'm sure that people are not going to follow our recommendation, many of them, but it's okay.
Other questions? Dr. Chopra.
Guillermo, thank you. What a great talk. I have a question about hypokalemia and hypoglycemia as mortality events in the context of DKA and HHS. So you alluded to this, but to me, it's not necessarily the fact that you're hypokalemic or hypoglycemic, it's the swing, the delta. And have studies looked at that in terms of dose response? Is there a way, if you start off at, 5.0 and end up at 3.5, you may qualify as being hypokalemic based on your cut point. But to me, that's very different than a 7 to a 2, right? Has the delta been quantified, and does that actually predict mortality better than just the binary low sugar, low potassium?
I'm sure there's better, but a good question. And we have all this data in thousands of people. I would look at it. I never thought about it, but you're right. Is the delta more important than the absolute number? Yeah, makes sense. Makes sense. And the message with hypokalemia is that the drop in potassium, it goes between 1 to 1.5 milliequivalent, millifol. Imagine that. Just because you activate the sodium potassium ATPase, so you bring potassium inside the cell. In addition, you correct the acidosis and you flush potassium in the urine when you start peeing. That's right.
Thank you for that talk. aside from the clinical pearls all in there, I was struck by the epidemiology at the very beginning. And you showed that the incidence of DKA and HHS has risen over time, essentially across the world. And I wonder what is underlying all of that. Is it simply that we have a bigger population just in general in the world, or is it that we have more diabetes, less access to care? I'm just curious from a population health standpoint.
Answer would be we don't know, but we discussed this in the areas of future research that unfortunately I didn't present to you. So the prevalence of type 1, the incidence of type 1 diabetes is increased in all over the world, especially in Europe. It's going up significantly. So there's more type 1. I'm here, Colorado, you guys. So that could be, and there are studies from these universities suggesting that if you instruct family members of the symptoms of hyperglycemia, you prevent DKA. Second is that, unfortunately, in adults, it's very hard to know. Third, we have not been able to prevent type 1 diabetes. Now we can delay it with these new medications, but we cannot prevent type 1 diabetes. In patients with type 2, education is still miserable. Less than 10% of patients with diabetes in this country receive good formal diabetes education. And if you're Medicare, less than 7%. So we don't educate, we don't use our tools to prevent the progression of diabetic ketoacidosis or hyperglycemic hyperosmosis. And there is a lot of social determinant of health, that's right. The cost of insulin was a factor. Hopefully it's going to be solved a little better, but it's not, it's going to be, continues to be an issue. But if you go outside the United States and Europe and Canada, in Latin America, where I travel a lot, people are still using MPAs and regular insulin because they cannot afford, basal insulin. So cost is still a very much an issue. What's going to happen in the future? I don't know if you know, but the Novo Nordisk is going to discontinue Levemir. We use Levemir at Grady because it's cheaper than Glargine. Now we're switching everybody to Glargine because in June it's going to go away. I mean, I don't know, there are so many issues, but we have a large section on how can you prevent and why is this issue about social determinant of health? Get family support and things like that. I don't know. Yeah.
How does starvation ketosis play in the role with the beta hydroxybutyrate and how to interpret that with the DKA?
We have a section on differential diagnosis that I deleted those slides. So they are, not everybody who has ketoacidosis have DKA, that's right. And number one is alcoholic ketoacidosis. And the difference between DKA and AKA is glucose levels. The level of beta hydroxybutyrate bicarbonate is exactly the same. We did studies comparing insulin levels is low, counter-regulatory hormones is high, inflammatory marker is exactly the same, AKA and DKA. The only way to differentiate is a good history. They are an alcoholic who have a binge, you get nausea, vomit, you stop eating, you develop DKA. Starvation ketosis. You develop the beta hydroxybutyrate levels in starvation ketosis is between 5 to 8 millimole. So a little less than DKA, but about the same. But it's a slow process, and you excrete ammonia in the urine. And people with starvation ketosis, the bicarbonate is almost never less than 18. So they don't have hyperglycemia in general, that's right. So they have normal low levels of glucose, and they have no metabolic acidosis, no difference in beta hydroxybutyrate. So yeah, we have a section on that, and I have slides, but I thought it was too many.
I think with that, we'll wrap up. Thank you so much for coming. We really appreciate it.